All right, good morning to everybody again in the audience. Welcome to House Labor, Health and Social Services Committee. We have 3 bills on the agenda today, and Clayton, if you'd be willing to call the roll.
Representative Clouston,
Here.
Representative Guggenmoss,
Here.
Representative Heft, Representative McCann,
Here.
Representative Ottman,
Here.
Representative Stivar, Representative Wasserberger, Representative Yen,
Here.
Chairman Rodriguez Williams. We have a quorum.
Okay, thank you, Clayton. Just a friendly reminder, if you're not familiar with the general decorum guidelines of our committee meetings, there is rules set out front of the committee room that you're welcome to read. And I hopefully everybody did when we signed in. The same applies to those that are testifying via Zoom. So just a friendly reminder, committee members, speakers, and audience members will conduct themselves in a civil and respectful manner at all times during this legislative meeting. Okay. And committee members and those who decide to testify in person or through Zoom, please remember to address the chairman at all times. We are going to move forward and we're going to put House Bill 121 on the table for consideration. This bill was introduced by its sponsor during our last committee meeting, who is Representative Daniel Singh, and I would like to invite him back up to continue to present this bill if there's anything left over, and then we'll move on to testimony. We ran short of time during our last meeting, so welcome and good morning, Representative Singh.
Good morning, Madam Chairman and members of the committee. I think we went through the bill pretty thoroughly last time. However, I would like to say that 2 days ago, when we presented this bill, that same day, the presidential administration made more changes to the policy, just emphasizing the need to get this in our own green books. And so while I fully anticipate the incoming presidential administration to rewrite the changes that were made most recently, I really do think it's up to us to make sure that this consumer protection policy goes into effect and that we're able to protect our citizens. Thank you.
Thank you, Representative Singh. Any questions or comments from members of the committee for Representative Singh? Representative Clouston.
Thank you, Madam Chairwoman. Representative, thank you for being here. I guess one of my concerns here is, as they make these changes, as this is a new law, we're gonna have to adjust all of our green books and make our laws adjust with it. So do you see a feasible way that we can do that? I guess my thought on this is probably needed, but maybe we're being a little preemptive. Maybe we should let the federal policy be in place for a while, figure out what they're doing, because this has changed a lot even in the last 2 months. Do you see a way that we could quickly keep up and change our state laws as these federal guidelines come in so quickly?
Representative Singh.
Madam Chairman, Representative Clouston, I would argue that the changes that have been made are detrimental to the intent of the original policy. And the fact that, for example, we've gone from requiring precise pricing to going to estimates just in the last few months and last years, that we need to put something in our books that are more static than the rapidly changing federal policies that are in place. So I think it would be imperative for us to get those in our own books.
Follow-up, Representative Clauston.
Thank you, Madam Chair. Thank you for that. I guess, again, but my concern will be is we have to follow the federal guidelines. Right? So even if we have these in our green books, as they make their changes, then we're going to have to make our changes to comply with those federal guidelines. So I guess the question again is, do you see a way that we can quickly change so we're in compliance with the federal guidelines as they change? Otherwise, we're out of compliance and we get into some reimbursement issues and that kind of thing with Medicare and Medicaid.
Representative Singh.
Thank you, Madam Chairman, Representative Clauston. To that, I would say that the bill that we have right now is even more precise than the federal guidelines that we have. And because of that, we're requiring additional information, not a lack of information, that it wouldn't put us out of compliance with the federal guidelines. But because we're requiring additional information, it's something on top of what the federal government is asking.
Any additional comments or questions for Representative Singh from the committee? Okay, seeing none, thank you, Representative Singh. Don't go far, please, in case there's more questions from our committee. I would like to invite any government agencies to come up if they would like to testify on this bill, House Bill 121. Good morning and welcome to Labor and Health. If you would each state your name and your agency, and we'll move on to testimony.
Good morning, Madam Chairman, members of the committee. My name is Stefan Johansson. I'm the director for the Wyoming Department of Health. Joined to my right by Ms. Laura Hudspeth, who is the administrator of our Office of Healthcare Licensing and Surveys. Appreciate the opportunity to be with you this morning. I want to keep my comments brief and specific to what the bill requires of the Department of Health, maybe a little bit of information of what those types of compliance review and enforcement actions look like through our Office of Healthcare Licensing and Survey. Just by way of background, Madam Chairman, Laura Hudspeth and her team we in the department and you all in the legislature put a lot on that office. And they do a great job. They are responsible for state level healthcare facility licensure, as well as life safety code, construction plan reviews on various types of healthcare facilities. That's really on the state side. They also act as a compliance and an enforcement office for what you've already been talking about with the Centers for Medicare and Medicaid Services in various conditions of participation that hospitals, nursing homes, other providers that treat Medicare or Medicaid patients or receive that funding. So the scope and the mission of that office is relatively broad. This bill with House Bill 121 adds some new provisions for us to incorporate for hospitals specifically into our survey and compliance review. And just want to talk about some of those a little bit. You direct the Department of Health through this bill, or the legislature would, to develop rules, compliance, and policy for how a standardized form would look to publish minimum and maximum negotiated charges on an array of services that hospitals provide, to format that report, as I mentioned, in a uniform way, to enforce corrective action plans for any facilities that wouldn't be in compliance, and to potentially look at civil money penalties for those that aren't in compliance and have not had an approved corrective action plan based on that initial review. I want to give Ms. Hudspeth the opportunity just to talk about very broadly, in case it's helpful to the committee, of what that process looks like when we talk about hospital survey, the frequency or periodicity of it, as well as kind of what those timelines would be when we would be enforcing something like this. But I do want to mention, Madam Chairman, before I hand it over to Laura, just one thing that I think is important. We would want, and I think the bill allows for a time period, obviously, to develop the rules, but also, as you heard in your first meeting here, I think we would benefit as a state from working with the provider group, should this pass, to develop a reasonable method of complying with this law and achieving its purpose. To that end, we did, as you heard on Wednesday, submit a very brief fiscal impact here, mostly on the administrative side for the work that would be incorporated into our Office of Healthcare Licensing and Survey. Those of you who have known me for a couple of years know that I'm very hesitant to just in any bill say this is going to require X number of positions or X number of dollars when there's certain unknowns. We would want to work through the initial phases of this implementation of what does that process look like, work with the providers, work with the stakeholders to come to an agreement on that. And then as you provide on page 21 of the bill, the opportunity for the department to make what we think are necessary adjustments to the law. I think we could do that through an interim period culminating in the next legislative session on exactly what those administrative impacts or additional workload, financial or otherwise, would be. And I hesitate to even offer that to you because it sounds like a punt, but at the same time, it's difficult for us to specifically peg what staff requirements and financial impacts on the administrative side would be. So if this were to pass, we would work to incorporate what's necessary, design the form, design the compliance process, and then hopefully have the opportunity through that section to make recommendations on rule changes, policy changes, administrative needs as the enforcement and compliance of this would evolve. But Madam Chairman, happy to answer any general questions. Otherwise, hand it over to Ms. Hudspeth just to give you a brief overview of what we envision the administrative process would look like.
Thank you, Director. Any questions of the Director before we move on? Okay, seeing none, Ms. Hudson.
Good morning, Madam Chairman, members of the committee. As Director Johansson mentioned, we do the licensure and recertification surveys for all of the healthcare facilities that are either licensed or certified in the state. In terms of the frequency of the surveys, they vary based on the provider type. Just to give you kind of an idea, for nursing homes, they're basically annually. For dialysis, home health, hospice every 3 years. For the purpose of this bill, the 31 licensed hospitals, they are surveyed between every 3 to 5 years. So that to help you with the frequency. We do not do recertification or relicensure surveys for the deemed hospitals because CMS has delegated that to accrediting organizations such as the Joint Commission. We do have a statute that says if there is a complaint or something of something that exceeds the requirements of the accrediting organization, so then we would go in and do those complaint investigations. Our investigations are unannounced unless it's a construction survey or one of our lab surveys. And if a facility is found out of compliance during one of those on-site investigations, we send a detailed written statement of deficiency that outlines what the regulation was and why we determined they were out of compliance. And then we request a corrective action plan. Once that corrective action plan is received and approved, then we do a revisit to verify compliance. And I have to say, on just rare occasions, facilities may not be in compliance, so we would recite the deficiency and work with them on another corrective action plan. In terms of this specific bill for our 31 hospitals, I see it would be more of an off-site review. I don't see where we would have to go on-site, and we could review the websites if there are any complaints, any updates to the list. We could do that off-site without having to go on-site, and we could meet those timeframes through our licensure statutes. I do want to mention, Director Johansson mentioned civil money penalties. Those are imposed currently. We have for nursing homes in the state. So if there is a significant deficiency that impacts the health or safety of a resident, CMS will impose a civil money penalty. And then the Medicaid portion of those monies come back to the state, and the nursing homes can apply for projects that improve the quality of care or quality of life of residents. So my office also reviews those projects along with the team Hospital or Nursing Home Association, QIO, and approve those projects. And then the money goes, we work on getting the money back to the nursing homes to reinvest in the residents and their quality of care and quality of life. So I think that kind of in a very high level nutshell is the process for healthcare licensing and surveys. And I certainly, Madam Chairman, stand for any questions.
Thank you, Ms. Hudseth. Any questions of Ms. Hudseth or the director? Sir, go ahead.
Thank you, Madam
Representative
Chair.
McCann.
I know you don't have an idea, when you do a survey or a audit at this point, about how long does it take? Just for the ones that you have now, just to get an idea of how long this might take?
Ms. Hudseth or director?
For our current process, where we go on site, it can be 3 to 4 days. We're on site for recertification survey with a team of surveyors. For complaint investigations, it can be a half a day, it can be 2 or 3 days with a number of surveyors, depending on what the allegations are and what observations and interviews and record reviews we need to do. I think for this process, just reviewing the website, making sure that all of the services are there and including updates, I think it would be much shorter, a few hours, I think, per process. So much shorter if we could do it in the office, which I think we should be able to do. And we can do interviews on the phone if we need to reach out to the hospital.
And Madam
Director.
Chairman, Representative McCann, if I may, I think the general theme here is we would be incorporating this new provision into our process that is already ongoing. So as Laura mentioned, it really does vary based on the type of survey, type of provider, type of complaint that we've received of the timeline there. But this would essentially be a bolt-on to what my goal would be if the legislature chooses to pass this, would be to, as best we can, incorporate it as efficiently as possible into the current staffing and current processes that we have, noting that, just to be blunt, it is additional, review, compliance, and survey work. So I do want to be clear about that, but we'll obviously work to incorporate it most efficiently. And as I mentioned, I'm really speaking here. You see a lot of the department shall in this bill, so I wanted to keep our comments specific to what this bill would require of the Department of Health. And I know there's likely folks in the audience, or as you work through this bill, where what I'm not speaking to is the process for providers, the administrative workload on them, which they can speak to. This is mostly about the Department of Health's process.
Any additional questions? Vice Chairman Otten.
Thank you, Madam Chairman. Director Johansson, how are you? It's been a while. Yeah, thank you. And whether or not this would be directed to yours or to the providers, one of the things that I've noticed over the last 8 years is that coding seems to be a problem. Because everything now is digital and online and things, which should make it easier. But through people getting training online and from different kinds of education or whatever you might call it, there's different programs that use different codes. And so when they go to a hospital or to a doctor's office, they're not universal. So could this be a mechanism to create a universal coding so that things aren't miscoded, which creates quagmire in the payment with Medicaid and Medicare and with the insurance companies? So could this actually, although it would be a lot of work in the beginning, but could it actually make things better for the people, the consumers, because those codes would specifically deal with a specific procedure or whatever that's going on. And so coming from the doctor's offices, the clinics, or whatever would be automatically the same.
Director.
Madam Chairman, Representative Ottman, wow, it's early in the morning, and that's a very detailed question, but it's an interesting question. To be direct, I don't know if this would create any clarity on the billing side. I see these as two separate worlds. So what we're talking about here is price transparency, a consumer being able to understand what a provider, charges at a minimum and maximum rate for certain types of procedures. To your point, however, we know, and those who have worked on this committee know, procedures are coded for the purposes of payment from various payers, whether that's Medicare, Medicaid, private insurance. And typically, you'll hear the term CPT codes. You'll hear the term ICD-10, which is kind of the Bible or the book of all of the procedure codes that are out there. We years ago went from ICD-9 nationally to ICD-10, and there's hundreds, if not thousands, of codes there. So that's a tall order for the consumer perspective to. It's just a difficult task when we think of something simplistically as we'd like to see a menu of services and charges. That makes sense as a concept to me. Translating that to every procedure code with price tags on it is a little more complicated if the goal is to have consumer transparency and consumer understanding. We would certainly, I think, providers, the health department, the whole system wants to work towards that. I'm not sure if those two things are incorporated into this bill. It's just a really kind of a detailed process there. And I feel for the public and consumers understanding healthcare prices, healthcare coding, billing. It's difficult. I also feel for the providers when those things change on a moment-to-moment basis when providing someone service. So someone's understanding going into a hospital of a procedure or a treatment regimen that they're getting there could change while they're in the procedure. And that's a difficult challenge to work through, just the reality of receiving healthcare. Things change minute to minute. Madam Chairman, Representative Ottman, I doubt I answered your question in any helpful way, but you certainly have my word with the Department of Health. We would work to implement and enforce compliance with this bill with fidelity to the best we can, and hopefully that would translate to consumer price transparency there.
Follow up.
Yes, thank you, Madam Chairman. Okay, because if I'm going to know how much I'm going to be charged, there has to be a price. I don't see where there's a difference there. I do understand that additional services may be implemented depending on, the severity or lack of severity of a procedure. But nevertheless, I know that coding is a problem, and I believe that that should be something considered in the development or looking into this, that could be a step to clean up a lot of things and work with it.
And Madam Chairman, Representative Ottman, I don't disagree at all. Just being clear of what I'm reading into the purpose of this bill versus what could be a good goal for the healthcare system that might be a separate track from this particular bill. I could certainly be wrong there, but your point's well taken.
Any additional questions or comments of the director? Seeing none, thank you for joining us. Okay, we will continue to move on. If there are any other government agencies that would like to come forward and testify on House Bill 121. Seeing none, we'll move on to the public. Are there any members of the public that would like to come forward and testify on House Bill 121? Seeing none, moving on to registered lobbyists. Come forward. Oh. Okay. Okay, let's see. I apologize. We'll take, if they fall under public comment, we'll go ahead and we'll do that. It looks like we have 3 for 121. Okay. All right. Go ahead and let the first one with the hands up in. Thank you, Clayton. Good morning. Welcome to Labor and Health. Thank you for joining us. If you could state your name and who you're representing, if you're testifying as an individual or working for an organization, and if you could just limit your time. We have a couple of other folks that like to testify after you, and then more in the audience. So thank you for joining us.
Thank you. I believe you're speaking to me. Let me know if you're not. Good morning, Madam Chair, and thank you so much for hearing my testimony on behalf of House Bill 121. My name is Marnie Carey. I am the president of Power to the Patients. It's a nonprofit, nonpartisan advocacy group that works on behalf of patients to access and achieve healthcare price transparency. So patients know the price of their care up front, and so healthcare is accessible and affordable. So obviously there have been a lot of great comments here. We're strongly in favor of the federal rule, which went into effect in 2021, but lacks enforcement. Only very few hospitals, despite the majority not being in compliance with the federal rule, have actually been fined, only about 14 or 15. And that's because CMS isn't an enforcement agency. They are a policy agency. And I really champion this bill because it does put some teeth as it codifies the federal rule and clarifies it. It also puts some teeth in the law and allows for enforcement through the Department of Health, which is so necessary for patients to achieve the benefits that healthcare price transparency could bring them. I'm going to speak briefly on just one anecdotal case, which is really systemic, and that is one of your residents, Nanette Hernandez. She's a 46-year-old truck stop waitress. She got COVID in July of 21, and she didn't have insurance. And she asked her boss for time off, and he didn't give it to her, so she quit. She went to an urgent care. They sent her to the hospital. She spent 3 days in the hospital on oxygen and recovering, and then was sent home with a $32,000 bill. In July of 21, when this happened, the hospitals were being completely reimbursed for all of COVID care for uninsured patients. And she never got that benefit. And I'm not sure if the hospital got paid or not, but they probably did. They did get $15 million that year in federal relief funds. She asked for financial aid, even though because she only made $350 a week, and was denied. She wasn't able to attend her summons because she had to work at her new truck stop job. And she also lost her apartment and had to move in with her mother at age 46. And now she works for $16 an hour, and 25% of her wages are being garnished to pay off a $28,000 loan at 7% interest. This should not happen in our system, in our society, and in Wyoming. And I think this is the kind of bill that would go a long way to championing healthcare prices and access, so she could hold the hospital accountable. For example, 1/3 of her bill is for a drug called remdesivir. She got 10 vials of it. Remdesivir costs, according to the manufacturer, the set-in price for uninsured patients is $394 a vial. The hospital charged Ms. Hernandez $2,124 per vial for this same drug, and over $10,000 for this overcharge. If we have healthcare price transparency, we'll have competition in the marketplace. These prices will come down, hospitals will be held accountable, and these egregious prices will be exposed. So patients like Nanette Hernandez and the other 100 million Americans who are in financial debt, struggling under financial debt, wouldn't have to face these weights on them again. They would be able to protect their physical health, but also their financial health. Thank you very much for your opportunity here today.
Thank you, Ms. Carey. Any questions? Representative Clouston.
Thank you, Madam Chair. And thank you, Ms. Carey, for being here today and for the work that you do. It's very important. I just have a logistical question that's kind of going through my mind. I'm thinking of all the services, all the medications, all the items that hospitals have, right? Thousands and thousands. And a lot of times their prices are changing based on the vendor or whatever reason. How have these other states, how have the hospitals adjusted their prices so quickly when we're talking about thousands of items, medications, and services?
Ms. Carey.
Thank you. Thank you, Representative, for the question. I think as in any industry, there's always volatility. When you buy a plane ticket to fly to Oregon, you know today what it's going to cost when you're traveling 6 months, but the airline doesn't know the cost of gas that day, what the weather's going to be like, whether they're going to have a staff shortage, but they still guarantee you the price. And hospitals have done the procedures they do enough times to know in general what it should cost to deliver a baby or to have your gallbladder removed, and they can guarantee those prices, and they can adjust them periodically, sure, year over year. But I don't think it's unconscionable to have the healthcare industry operate just as any other industry does when faced with a multitude of factors that affect their pricing. It's called business, and I think they should be able to run it a little better than they're doing now.
Thank you, Ms. Carey. Any further questions? Representative Yin.
Thank you, Madam Chairman. Ms. Carey, so, like any regulation, that it comes at a cost, either a cost of enforcement and or a cost of implementation. The federal rules have been made, and so no matter what, there is going to be a cost for implementation. My worry, I guess, with a state law is, would that create more cost of implementation if we have two different sets of rules? And if we have two different sets of rules, is that cost going to be passed down to the patient? And maybe what your thoughts would be on if we just created an enforcement regime where we enforce the rules that are in place rather than create a second set of rules as well.
Ms.
Thank you.
Carey.
Thank you for the question, Representative Yin. Yes, there wouldn't really be two sets of rules. What this bill does is codify the existing federal hospital price transparency rule. And according to CMS, and this rule has been in place for 4 years now, so hospitals have had plenty of time to comply, although only 21% of hospitals in the United States are complying. But the CMS ran a study that said it will cost hospitals $10,000 to come into compliance. So it's not a big line item for most hospitals. And it would be the same for the state hospital. The only thing that would change is now there would be a lot more accountability if the Department of Health actually monitored the compliance and enforced the rule. I would hope that there would have to be no enforcement because the law would generate 100% compliance, but it should not be more onerous on the hospitals than it already is. And the lift is not that heavy according to CMS statistics.
Thank you, Ms. Carey. Any further questions? Okay, thank you for joining us.
Thank you.
Is there anyone else out there? Okay. Okay. And Clayton, if you wouldn't mind reading me the name, I can't see that far, what's in the little box from this angle. So thank you.
Good morning, Madam Chair. Thank you for the opportunity to testify today about House Bill 121. My name is Ilaria Santangelo, and I'm the Director of Research at PatientRightsAdvocate.org, a nonprofit, nonpartisan organization seeking real prices, real choices, and a functional marketplace in healthcare. We strongly believe that the single most important way to achieve this is through system-wide healthcare price transparency. I led the team that created the recent Hospital Price Transparency Compliance Report, which found that only 21% of hospitals nationwide were fully complying with every requirement in the federal price transparency rule, in effect now over 4 years. Wyoming hospitals fared worse at 0%. Over the past 4 years, the language and the intent of the federal price transparency rule has been watered down and rolled back by allowing for estimates, algorithms, and percentages in these machine-readable pricing files instead of actual and accountable dollars and cents pricing. What good is a pricing file that contains no prices? CMS even recently published a frequently asked questions and guidance that stated hospital prices do not represent either an individual's out-of-pocket obligation or a guaranteed price. And they strongly encourage individual consumers to utilize hospital and payer price estimator and comparison tools. This language was not in the original hospital price transparency federal regulation. I also think this is really important and something I think we all know. Estimates do not work. They provide no accountability and often end up thousands or tens of thousands of dollars more than quoted. And this bill recognizes that. The estimates hospitals actually provide patients disclaim that it's not going to be the final price and require patients to check a box to make sure that they agree. We don't tolerate this in any other industry. Let's stop tolerating this in healthcare. The current administration is putting forth guidance that no longer stands to represent patients in their right by law to shop for care that they need at prices they know they can afford, but the special interest groups that continue to capture our government agencies to convince us as patients that we don't need access to actual upfront prices, which we all know is not true. We work with patients who were sick and scared, trusted their hospital and the estimate that they were given, only to be stuck with bills they did not see coming nor could afford. And to add insult to injury, they get liens put on their homes or their wages garnished because without accountability, hospitals can charge whatever they want. House Bill 121 will protect patients against these predatory billing practices and is why Wyoming needs to codify the original intent and language of the Trump price transparency rule by requiring actual dollars and cents prices so all consumers can shop for the best quality of care at prices they know they can afford. And this was mentioned earlier, so I just want to touch on this. No hospital.
Miss Santangelo, I believe
Yeah.
it was called. Yeah. If you could just wrap it up, please. We
Okay,
have
yep.
lots
No-
of folks to testify
No
here.
hospital will be out of compliance with the federal price transparency rule by posting dollars and cents prices. They will just be avoiding the loophole that has been implemented to allow them to post non-accountable pricing information such as estimates, algorithms, and percentages. Thank you.
Thank you, ma'am. Are there any questions from the committee? Okay, seeing none. Thank you for being with us today. And for
Thank
your
you.
testimony. Please bring her in. Good morning and welcome to Labor and Health Committee. If you just please state your name and who you're with, and we'd love to hear your testimony.
Good morning, Madam Chairman. My name is Darcy Gudger, and I am representing myself as somebody who is going to put flesh and blood to the discussion that is happening right now. I am here because I'm from Mills, Wyoming. I'm here in support of this bill. Transparency would improve and expedite access to critical care. My husband faced barriers to care in December of 2024 at Banner Health in Casper. Initially, he was required to pay 50% of the estimated cost up front. Why? Because we have Christian Healthcare Ministries, a sharing plan, and have to make self-pay arrangements until the cost is reimbursed to us after the billing is complete. If we had traditional insurance, the surgery would have been scheduled and performed in a timely manner. The estimated cost was not justifiable or provable by CPT codes. The quoted costs were significantly higher than national averages, which Christian Healthcare Ministries balked at. We made calls to multiple state representatives and Senator Barrasso. These folks contacted Banner on our behalf, and the prepay was reduced. Because the cost was still above national averages with no justification or CPT codes, CHM was not able to help us with the prepay. Friends and family had to launch a Give, Send, Go campaign to cover the cost by Banner's deadline. In the end, the surgery was determined to be life-saving, and Banner worked with us. The lack of transparency, the bureaucracy of billing, put excess strain on a patient dealing with a critical condition. If Wyoming had a transparency requirement, the hospital couldn't play financial games with us. We would have been able to let CHM know the exact cost of the surgery as well as provide CPT codes. CHM would have been able to make the prepayment. Requiring a down payment for necessary surgery is an issue for another bill. No other industry requires payment plans or down payments on arbitrary numbers. Most industries have fixed rates for all clients. They don't size up consumers to determine how much they can get out of the client. They also don't bill before itemized statements are issued. Why are hospitals, entities providing life essential services, allowed to resort to such exploitative practices? Transparency in pricing would prevent hospitals from inequitable billing based on their assessment of one's ability to pay or not. In addition, hospitals should have to justify their pricing. The level of transparency would prevent them from using some patients as a mean to make up for losses due to non-pays, as well as Medicare and Medicare shortfalls. Patients should be confident that they are paying for their own care and nothing more. Transparency in billing has a potential to help Wyoming providers. Currently, many have to travel out of state because services are less expensive or transparency laws are already in practice, such as in Colorado. If patients can weigh the total cost of travel and room and board, they may find Wyoming care to be more economical, keeping dollars in states. Keeping patients in dollar in state will in turn attract more providers, which will create a more competitive landscape in Wyoming. A more competitive landscape will break the monopolies we currently have, giving Wyoming citizens the best possible care. For all of these reasons, I support this bill and urge a yes vote to bring it to the floor. I stand for questions.
Thank you, Ms. Gudger. Any questions from the committee or Ms. Gudger? Okay, seeing none. Thank you for your testimony and for joining us this morning.
Thank you, Madam Chairman.
And I believe that's the last one. Thank you. All right. Continuing on with testimony on House Bill 121, registered lobbyists. Okay, yep, and go ahead and come on up as well, too, so we can move along. Thank you. Representative Locke.
Thank you, Madam Chair and Committee. I just wanted to put my support behind this bill. This is common sense doing, transparent pricing to the public. This is common sense. Everybody knows this is, people shouldn't have to vote on the bill to know what's in it, and that's what's happening in the healthcare industry. We all laughed about that when it was said in our in our federal government, and that's what's exactly happening day to day with people in our healthcare system. Transparent pricing is critical to our folks. Putting the right support behind it and the right teeth behind it is the right answer, in my opinion. And I just wanted to give my support. Thank you.
Thank you, Representative Locke. Any questions from the committee for Representative Locke? Okay, seeing none, thank you for joining us. Moving on, registered lobbyists, please come forward. Whoever would like to go first, please state your name and who you represent, and we will listen to your testimony.
Madam Chairman, committee members, Eric Bully, President of the Wyoming Hospital Association. I think we'll all introduce ourselves and we can, if that's okay, Madam.
Members of the committee, Josh Hannes. I'm also with the Wyoming Hospital Association.
Thank you. My name is Tim Thornell, President and CEO of Cheyenne Regional Medical Center and a board member of the Wyoming Hospital Association. And just for the record, I'm not a registered lobbyist.
Thank you.
Madam Chairman, I'll kick it off, and I'm glad we started with an easy one in our first meeting. This one is a little bit more complex. And I've been giving this a lot of thought. I thought what might make some sense is to hear from one of our providers and talk about what they have done to comply with federal law. And I think we'll let, if that's okay with you, Mr. Thornell talk about his experiences, Cheyenne Regional, and then we have some other thoughts after that.
Please, Mr. Thornell.
Great. Thank you, Madam Chairman. At Cheyenne Regional Medical Center, we've adopted the price transparency laws and rules from the federal government, have been in compliance for quite some time, are today. Just this week, I went and verified, looking on our own website, on our homepage, our first page that you'll see. On that page, you can click on price transparency. And with one click, it'll take you to a page that gives you a choice to download a machine-readable file for everything, or do a lookup for any individual price by payer as well. So it is really pretty easy, pretty accessible to achieve those prices online. In addition, I know people talked before about price estimators. Those are really two separate issues, and we do price estimators. So as patients come in and present to the hospital, we can estimate what their price is. As you can imagine, that becomes much more difficult in the emergency department when they're not even able to tell us frequently what all their issues are. So we do our best, of course, to estimate, but those are really two separate issues, both of which we are in compliance with federal rules and guidelines. I have an article from Becker's Hospital Review dated January 3rd, 2025, so only a couple weeks old, which says CMS has fined 17 hospitals in 10 states and Puerto Rico for alleged price transparency violations, and they list them out by state. Wyoming has 0 hospitals on that list. So I would suggest a couple of things. One, the federal rules are working. We do have price transparency. We are listing our prices out there. CMS is absolutely an enforcement entity. They enforce many of their rules quite frequently, including this one, as just demonstrated by providing fines for hospitals that are out of compliance. So we do find that, state law, well, this is mimicking mostly of what is in federal law, will be duplicative and therefore will be onerous and will be an administrative burden to hospitals. And we all know administrative burdens lead to administrative cost burden as well. And I believe, as we frequently find when there are state and federal laws, at some point they are going to diverge. The federal government most likely will make some changes, and then it becomes two separate rules that we now have to do our best to be in compliance with, and sometimes they become in opposition to each other. And the challenge to that is just quite extraordinary as time moves along. So those are some of our future concerns with having duplicative laws. And we again assert that the federal laws are serving their purpose.
Thank you. Any questions of Mr. Thorell? Representative McCann.
Thank you, Madam Chair. Your pricing, is it in the dollars and cents, or are we using the logarithms and whatnot?
Mr. Thorell.
Madam Chair, Representative, we provide dollars and cents. So you can see on that what it is, and our estimator also will provide dollars and cents. Again, two separate things, but you can look up the price. And we do our best to estimate it too by your insurance company. So if you have insurance, that of course every insurance company reimburses, pays different, requires different payments from the patient. So we do our best to provide what that actual cost will be.
Follow-up, Representative McCann.
Thank you, Madam Chair. I'm assuming you've compared the federal laws to this, and you really think they're two separate laws as opposed to complementary?
Mr. Thorell.
Madam Chair, Representative, as I've read through them today, and certainly Mr. Bullock can comment further on this, I find the laws to be very complementary. So therefore, I'm suggesting they're quite duplicative today. But then I also suggest that as time marches on, one of the two, state or federal, more likely the federal, will change these rules. And then they are not complementary and just become more onerous to adhere to.
Additional follow-up, Representative McCann.
Thank you, Madam Chair. We're starting to get into probably next door at judicial, but as a contrast to what you're saying, wouldn't you go by the federal law anyway? Using the supremacy clause, we got to follow federal law as opposed to state law?
Mr. Thorell.
Yes, Madam Chair, Representative. So yes, in our world, federal law is supreme to what we were doing, and certainly CMS is the main guardian over all things healthcare for hospitals.
Okay, thank you. Nothing further.
Any additional questions of Mr. Thorell? Okay, additional testimony?
Madam Chairman, if I could just comment to Representative McCann's question there. I think your question is great, and we faced this for the last 3 years in the legislature as we battled through the COVID issue. There were very specific things that we had to adhere to federally. The state has tried to pass laws that would have preempted federal law, and we would have been put in the middle. And federal law, they wield a lot of power. They weaponized our conditions of participation, could withhold our Medicare payments, could withhold the ability for us to admit patients. that's one thing we're trying to avoid here with this particular bill. And so I think it's a great question that leads us into the question why. I have to tell you, I got home last night, had dinner by myself. My family was gone. I sat there and thought about this. I was up all night thinking about what testimony I could provide. And I feel like we've come up with a solution to a problem that is already being solved federally. And I'm worried what could happen. As was testified this morning, there have already been changes made to the federal law, and we expect that there will be additional changes made as soon as President Trump comes back into office. In 2021, I believe, when he passed in his last year, these rules were rolled out. They were then upheld by the Biden administration, and it took a period of time because in the meantime, we were going into COVID, and so it took a little bit of time for us to get up to speed, but testimony received from, I wouldn't say it was the public, but from an interest group, our hospitals have done what they can to comply, and zero is wrong. You can look, we've looked in all of your communities. If you go to your hospital websites, you'll find exactly what is required by law. There are enforcers and there are groups out there that are trolling our hospitals, wanting to turn us in. And so we have done all we can to comply with that. There's a lot of interesting nuances and things that have been talked about. I'm not going to get into the examples that were shared because you're only hearing one side of the story. And I think for HIPAA reasons and other things, we can't really talk about those cases, but they're not exactly as been presented to you. And that's where I'll leave it with the examples that were used. They're inflammatory and they're maddening to listen to. But there are two sides to both of those, and this is not the venue where we can talk about those. When it comes to estimates, I'm going to use my own experience. When my wife and I were first married, I was playing basketball and I hurt my knee. I went to the doctor and the doctor says, you need to come in, we're going to scope your knee and you're going to have a meniscus repair. So I went and presented to the hospital, went through the process, and when I woke up in the recovery room, I noticed that it had been hours instead of the allotted time, and I tried to get out of bed. I was so upset about that. Come to find out that when they got in there, not only did I have meniscus problems, but I'd ruptured my ACL, and so they'd had to repair my ACL. So there was an estimate for a meniscus tear, but when they got in there, they found out that it was much more complex and they needed to replace my ACL while they're in there. So when we talk about estimates, when we talk about healthcare, it's not exact. When we get in there, we find things that need to be fixed. And so estimates are great, but we also need to realize that there are other things that feed into how these bills are generated. And not always are the estimates going to be exactly accurate. There's billing for anesthesia, there's supplies, all kinds of things that may go into, once we get in there, kind of like a plumber, we find other issues. You've asked some great questions, Representative Ottman, about coding. I don't think this bill can fix that. I would tell you that we're required to post our 70 most common codes in the manner in which is prescribed by federal law. We do that. A few years ago, we used to have what are called ICD-9s. There were about 7,000 codes in the ICD-9. And then we enacted ICD-10. We went from 7,000 codes to about 70,000 codes. There's a code in there for a turtle bite. There's all kinds of things in there. So I don't think we can fix coding in there, but we do have DRGs, diagnostic related groups. Those are what we use to bill. We use HCPCS codes for providers. I don't think there's as much problem in coding as you would think. I think there are some issues in understanding our bills. And I think that's where we could do a whole lot better job. One other thing I would add, this was an unfunded mandate. When President Trump enacted this, there was no funding that came to us to be compliant with this. And there is expense that goes into it. I think it was between $10,000 and $15,000 per facility to get one of the software companies to be able to put this on our website. Some of them are much more expensive. And then there's annual upkeep. And I think you would see that some of them are very advanced and complex. Some of the others aren't, because of resources, aren't probably as good as the others. But what you did hear from the presenters of this model legislation, and that's what this is a model legislation that's being pushed by a group and we're trying to pass it across the country. You heard from the presenter from Colorado that our rurals are doing a very good job. And 20 of our hospitals in the state are critical access. They're small rural hospitals. But realistically, all but a couple of our facilities in the state qualify as rural. We are doing a pretty good job with this. There's room for improvement, obviously, and we're working on that. But aside from that, I think the consumers could do a whole lot better. Our consumers aren't using these tools. It's not widely used. And I think I'm gonna let Josh talk about what we did as an association more than a decade ago before this even became an issue. But the consumers aren't working with their insurance companies. They're not finding out what their payments are. They're not using these estimators. These estimators are used by other groups. And so I'm not sure we're really going to fix a problem here. But I'll let Josh talk about what we've done and then we'll conclude our comments.
Any questions from the committee? Okay, seeing none. Mr. Hannes, and if we could just stay on the bill and off the coding topic. Thank you.
Of course. So just to give some context for what the Wyoming Hospital Association, Wyoming Hospitals have done since 2012 around transparency, is on our website, you've had access to the charge master. So you could go in there, you could look at the procedure that you were expecting to have, and you could take that information to your insurance company for free and say, based on the plan that I have, my deductibles, copays, and whatnot, what is my out-of-pocket responsibility likely to be? And that's still something true today. Obviously, we have more sophisticated tools online. Our hospitals are in compliance. And in fact, I'd be happy to send you all the links to your community hospital so you can see what your local facilities are doing to be in compliance and what's available in the spirit of transparency. So I think there are things that can be done, and based on your payer is going to determine very much your out-of-pocket responsibility depending on your plan, like I said, and that's an option that any patient has the ability to take advantage of. One other thing I did want to point out is there have been changes to the federal law over the years, and there are changes scheduled for 2025. They are more stringent. They are more consumer friendly in the types of data elements. They're adding drug pricing in 2025. These are not rollbacks that the current administration is doing. They're moving this transparency even further. So I would leave my comments at that. I think the others covered it, but happy to answer questions.
Thank you. Any questions from the committee? Representative McCann.
Thank you, Madam Chair. I think part of the driver for this, and I don't want to get into the pricing or anything because that's out of the scope, but I think this is why this is being, or one of the main drivers of why this is happening, and use myself as an example. I had an emergency room visit with my daughter and a $3,500 CT when I can go around the corner and get the whole thing done for $800. Why the discrepancy? And I know that's out of the purview of this meeting, but I think that's a main driver of why this is happening. Just a comment.
Representative McCann, thank you. Any follow-up? Okay, any additional questions?
Madam Chairman, if I could, just in closing, and we can have that conversation. And
Mr. Boley.
Madam Chairman, and I think you and I discussed earlier, maybe having a healthcare 101 after the session so we can do some education with the new committee. So I won't get into that because it has to do with fixed costs and a whole lot of other things and community benefit. But what I would say is I would ask that we take a thoughtful approach to this. I don't think this legislation is necessary at this time. I think there are things that we can work on through this committee. I find it interesting that we want to pass additional laws when we already have federal laws in place and that we are struggling and doing our best to comply with already. And like we talked about earlier, I don't want to get into a situation where we have conflicting laws and we have to decide which of the two masters that we have to honor and follow. We're committed as an association. Our hospitals are committed to doing the best that we can, and I think we are. I think the last thing I would add is that our hospitals are struggling right now. I'm concerned, honestly, that we could potentially lose a hospital during this session and have it closed. Adding additional financial and administrative burden to struggling hospitals is a concern to me. And quite honestly, I really don't see any purpose to this as we try to adhere to the federal law. With that, I'd answer any questions, and I thank you.
Okay, thank you all for your testimony, for being with us this morning. Any additional registered lobbyists? Okay, seeing none, we will close public comment. Committee, what is your pleasure? Bill's been moved by Vice Chair Ottman and seconded by Representative Guggenmoss. Okay, discussion committee. Amendments. Representative Klauston.
Madam Chair, I think this is a very important topic. I think with the new administration coming in, and this is really a larger topic than maybe we all appreciated initially, I'm really leaning towards maybe asking the committee to table this and take this up as an interim topic. I just think we have a lot of work to do here, and I'll be interested what happens in the next few months as the new administration and the new health department rules come in. So just wanted to bring that up for a topic of discussion if anybody else would be open to that suggestion.
Any other comment on the bill, House Bill 121 from committee members? Okay, seeing no other comments. Does the committee wish to work the bill? We can work page by page for amendments. If anybody has any amendments, please speak up now. Okay. No proposed amendments on House Bill 121. The bill's been moved, seconded. Clayton, if you would call the roll.
This is a roll call vote for House Bill 121. Representative Klauston.
Aye.
Representative Guggenmoss.
Aye.
Representative Heft. Representative McCann.
Aye.
Representative Ottman.
Aye.
Representative Stivar. Representative Wasserberger. Representative Yen.
Aye.
Chairman Rodriguez Williams.
Aye.
Madam Chairman, that is 7 ayes.
Thank you, committee. House Bill 121 has a recommendation of do pass. Representative Singh, you'll present that on the floor. Okay, we will move on. Still have ample time to keep working, committee. We will move on to House Bill 76 for the committee's consideration. It's now on the table, and we have Representative Brown with us today, the sponsor of the bill. Welcome, Representative Brown, and if you would please present your bill to our committee.
Thank you, Madam Chairman. Appreciate your time today, and I appreciate you bringing this bill forward as quickly as you did. I'll try to make this as brief as possible because I know you have at least one more bill out there as well. What I want to do is start off with a very brief story of where this idea came from for me. So I was knocking doors in August, came across an elderly woman in my district who said, you know, my daughter just had a major issue and I'd like you to talk to her about this. Well, her daughter's not my constituent, but she was, so I honored that and I said, yeah, absolutely. So I sat down and had a coffee with this young woman. 42, I'm going to try to keep things a little broader. I found out recently that when you start talking a little too specific, some of the insurance companies can dial down and start finding out information a little quicker than I was expecting. So we'll just say a 40, range in the 40s of a woman. Went in to her OBGYN with hip pain, found out that she had fibroids, which are growths inside the uterus. When she went in, the OBGYN made a determination that, you're past your childbearing years, you've had the discussion with your husband, we should probably go ahead and do a hysterectomy. At this point, this is the fibroids are not going to be going away anytime soon. We can take them out, but there's a good likelihood that they'll come back. So we should just probably go ahead and do this. Went ahead, did the prior authorization. The prior authorization came back, was declined, said you need to do a hysteroscopy, which is an intravaginal operation, which they go in and basically just scrape the lining of the uterus and any of the fibroids out. And they authorized that, and they said that's what needs to be done at this point. The hysterectomy is not approved. So they appealed, and that appeal was also denied. That appeal was handled by a doctor in Connecticut. Long story short here, the process and the procedure went through as a hysteroscopy. And in the process, one of the things that you cannot see doing an intravaginal process is you cannot see blood flow to some of these fibroids in some cases. In this particular case, they hit a supplying blood vessel, and that blood vessel turned into a life-threatening bleed. An emergency surgery was performed, saving the young lady's life, and a hysterectomy was performed on the table that day. So this patient went in and basically expecting to have a 2 to 3 week recovery, ended up having a 6 to 8 week recovery, had to miss a lot more time off of work than originally expected because she was told, no, you're not going to have a hysterectomy. You're going in for a fairly benign transition. So as that process unfolded, they were not interested in suing. They were not interested in litigation. They just wanted to file a complaint against the doctor in Connecticut that had not allowed this process to come through. They said, look, this is my body. This was what was recommended to me by my doctor, and this is what I wanted to do. I had made this decision, and this doctor told me, no, I couldn't do it, and they don't even live here. Why in the world are we allowing doctors in other states to approve or not approve? And in my mind, this is Landon Brown's mind, why are we allowing doctors to practice medicine in the state of Wyoming where they cannot actually be held accountable to our Board of Medicine? So that is exactly where this bill came in. Take you just a brief minute back here. Last year, this bill was passed through this body. Very similar language was actually in the original bill. I was unaware of that until about 2 weeks ago when I published this bill and put this out on the website, and I was contacted by a few individuals saying, why are you doing this? This is going to make us look like we're going back on our word. We kind of compromised here, and this isn't. I said, I had no idea. I apologize. That's not at all. So I want it to be very clear. This is a constituent concern from me. This has nothing to do with any of the people that will come up and may or may not speak on behalf of this bill. But this came from a constituent on the door somewhere in August. So I want to be clear here. Some of the insurance companies will come up and they will give you guys some very valid points. I sat down and had a very good conversation for about an hour with one of those insurance companies 2 days ago, and they bring a valid point. And these IROs, or the independent review organizations, cannot be held to the standard of guaranteeing that every single doctor that they hire to do these reviews are going to be licensed in Wyoming. They could. They're probably not going to, right? We could force their hand and we could force this to happen. That's not the intention of this bill, is to say, hey, look, you guys are going to struggle to find this and I want to make this harder on you guys. But what I'm trying to do is protect our citizens in this state. And if they have recourse, right now they have none, but they would like to be able to go to the State Board of Medicine and file a complaint and have that complaint litigated at the proper level, maybe not in the court system, but with the department that handles or oversees this area, which is the Board of Medicine. So not all patients are interested in litigation. Some just want to file that complaint. Some of these people just want this information lodged and they just want to have their voice heard. Right now, they don't have that opportunity. So Wyoming families are being given the green light from doctors in other states, or the red light for that matter. We need people to have access to those doctors and recourse, just like the doctors that work and live here in this state. Other stories of similar situations have happened since I filed this bill. I've heard of at least 3 other stories. One that's a very unique story that was just told to me last night. And it kind of goes down a little bit different path, but it actually involves another state agency with workers' comp. and some issues going on with that, and how we have a doctor that is investigating a particular bill, or I'm sorry, a particular patient, filed something for workers' comp, and we have no recourse on that particular doctor because they're not licensed in this state. So I don't want to divulge any constituents' names. If my constituent does decide to come in, they were hoping this was going to be held out until next week. I don't know if she was able to get off. That's up for her to disclose this if she would like to come in. One thing that I want this committee to know is I'm not against compromise. And I would ask that if there's major concerns that the people behind me are going to bring forward and you feel that those need to be addressed, I am more than happy to sit down and work with any and all interested parties to find a way that we can make good policy better policy. Would I like to have this bill pass as is and make sure that everybody has a license in the state of Wyoming when they practice medicine here? You bet. Am I going to put that onerous situation on top of everybody? Not necessarily, and I think we can work on that. I have worked hand in hand now after filing this with the Medical Society, with the Hospital Association, talked with all the insurance companies that are out there. It's no surprise here at this point, we have, an unstoppable force meeting an immovable object. So this was a compromise last year, and I understand that if we go back on that compromise, there's going to be a little bit of heartache on both sides, but I'm willing to compromise as well. So the last thing I want to leave this committee with before I answer any questions is patients in Wyoming are being denied by doctors in other states, and our constituents literally have zero recourse once these decisions are made. This is a consumer protection bill, not an insurance bill. This is good policy and it can be made better, so please forward this and allow the interested parties to massage this and make this good policy better. Let's protect our people in the state of Wyoming, and with that, Madam Chairman, I'll stand for any questions.
Thank you, Representative Brown. Any questions regarding this bill? Representative McCann.
Thank you, Madam Chair. Welcome to my world. I deal with this every day. Most of these doctors that work for the insurance company. And the insurance companies are the ones that put out the rules of engagement. So I'm not sure we're going after the right person. As far as, it sounds like you want to go after the doctor in another state. When the insurance companies are the ones that make up the rules for those doctors to go by. This is a major problem, for sure. I deal with this almost every day. I have to do peer-to-peer reviews. So I'm just not sure
Representative Brown.
Madam Chairman, Representative McCann, if you take a look at the bill, the language in the bill is fairly simple, and what you'll notice is 2655-104. Right now, it says otherwise, unless otherwise required underneath Wyoming law, current and unrestricted license to practice within the scope of their profession in, and right now the language we say, you can be practicing in any state, just as long as you're a practicing doctor, you have the authority and the ability to make these determinations of prior authorizations and appeals. We are trying to take that language out. That was the language that was compromised on last year. And what I'm saying is those doctors that are making those decisions need to be licensed in the state of Wyoming and need to be held to the same accountability that the doctors who are living here, working here, and making the determinations here in Wyoming. That would require these doctors who do work for these insurance companies and or are hired by these insurance companies to then be licensed with the State Board of Medicine. Roughly anywhere between 5 and 10 days if there's reciprocity with that state and if they have all their documentation together, not an onerous and exorbitant amount of work to get done.
Vice Chair Ottman.
Thank you, Madam Chairman. Representative Brown, how, or do you know how this will affect, there's a big move in the direction of telehealth and how that is supposed to take a lot of the pressure off of doctors or rural hospitals where there isn't always physicians available. So how would that affect those doctors in their certifications?
Representative Brown.
Madam Chairman, Representative Ottman, This really wouldn't have any determination as far as telehealth or anything along those lines. This is strictly on prior authorization for procedures and appeals of those prior authorizations and whether or not those procedures are approved or denied by the insurance companies. If there is any type of telehealth situation associated with this, I am not aware of that. Director Bowenblust may be able to give a little bit more information on that, but to my knowledge, there wouldn't be any adverse action on this particular piece of legislation.
Follow-up, Vice Chair Ottman.
Madam Chair, and please, just for clarification in my mind, because this isn't, it just isn't quite clear. If a person is using telehealth, then they would have to get prior authorization through that telehealth provider, is that correct?
Representative Brown.
Madam Chairman, Representative Ottman, in not all cases, no. So the prior authorization, there may be prior authorization if you're thinking, psychiatric care or something along those lines. That prior authorization, and this would be a much better discussion, to be honest with you, with some of the providers. This is certainly not my world, but they may require prior authorization, but at that point, if they are practicing medicine in the state of Wyoming, they're already licensed. So if they're providing the telehealth prospect here, they are, I believe, and again, I could look to the director to ask that, but I do believe that they are required to be licensed in the state of Wyoming if they're providing medical care and a medical service to the state of Wyoming citizens.
Any additional questions from the committee for the sponsor of the bill? Representative Clauston.
Thank you, Madam Chair. Thank you, Representative. As you know, prior auth is near and dear to my heart, right? My bill and my task force, and worked hard at it. And thank you for your support and your work on this. I guess my question would be is, can patients in Wyoming, say this doctor in Connecticut, can that patient file a complaint in Connecticut and explain the situation that way? So I guess the question is, I'm really worried about the specialists, right? There's certain areas where there's very few specialists, and I don't want to limit our choices in Wyoming. Do you see that a patient could, like in this situation, complain to the Board of Medicine in Connecticut and have the same results?
Representative Brown.
Madam Chairman, Representative Clauston, I would suspect that they could probably go through that process. One thing that's nice about the state of Wyoming is we're one big city with very long streets in between. And we have the ease of running into our governor or our representatives at dinner or at lunch or something along those lines. When you start talking about a state like Connecticut or New Jersey or anywhere else where you have these large organizations and large government agencies where these doctors are being licensed elsewhere, it's not as easy. Right? And so this is a solution that was over a couple of cups of coffee. I decided I thought this might be the solution, is to say, hey, look, if you're practicing in the state of Wyoming, and in my mind, this is you could split this hair and you could say this is a decision of whether or not you're practicing medicine or whether or not you're practicing insurance. And that's really what you're talking about right here. And in my mind, this is practicing medicine because we're talking about people's livelihoods here. In this particular situation, this was a very scary situation. I guess I want to be clear here. It also cost the insurance company more money to have an emergency surgery done at that point. So in the short run, if they would have just approved the original hysterectomy and gone through that process and not gone through the Connecticut doctor, we probably wouldn't be in this situation. We wouldn't have this problem. And then to ask a state of Wyoming person who is going through their process here in the state of Wyoming to file a complaint against a doctor in Connecticut that they have no idea who it is, becomes an onerous process. They're going to have to file up, they're going to have to contact the insurance company, find out if they can get that information on who made this call, go through all that entire process, and then go to that Board of Medicine and hope that they can get the answers that they can here. In my opinion, I think it's a lot better to do things at home and in our own backyard than force our citizens to try to go file these complaints in other states.
Thank you, Representative Brown. Any additional questions of the bill sponsor? Okay, seeing none, thank you. Stick around. Okay, we will now open it up for public comment on House Bill 76. If there's any members of the public that would like to come forward, any government agencies that would like to come forward. welcome. Please state your name, which agency you're with, and we'll hear your testimony.
Madam Chair, thank you. Committee members, my name is Jeff Root. I'm the Commissioner of Insurance. To my right is Tan Howard, my deputy. I can't help but note the other agency next to me, but waved me to go first, so if it's all right, I'll just do. All right. A couple of brief points and some of the questions that were brought up. It's interesting. I will not touch whether that is the practice of medicine or not. That's not my purview. I will leave that up to the other agency to decide. If someone across the country looking at papers with a contract for an insurer makes a decision or a recommendation, that's not for me to say, so I will let them speak to that. I would offer, though, that just so we better understand this, there's built-in appeals of any decisions in these insurance contracts with these health carriers. And the initial appeals will involve, for example, a specialist, a doctor that's in the employ of the insurer. And then if the consumer doesn't like that answer, then they can go to an external independent appeal. And that's these people that are these independent review, that belong to an independent review organization. They're nationwide companies, all sorts of doctors, all sorts of specialists. And think of all the different specialists out there. I think, you might find a doctor or two that could wave into Wyoming. But when you think of dozens or if not hundreds of specialists that are willing to do that, that's a different question. And that's where some of my comments will go to. I wanted to touch on the complaint process. If the constituent had mentioned it to us, we would have taken in a complaint because we view that as something that's on the insurance side of the house, the insurer part of that appeal process. So if you have constituents like this, send them our way. We will take a complaint, we will look into it. And if there's something we can do in the process to help them, we will. So back to my initial points, okay, thank you. We use independent review organizations in our statutes, in our daily operations. We perform independent reviews, or we don't, but we bring in IROs when a consumer appeals a medical necessity determination. So for example, if something is done, it's actually concluded, a procedure, and the insurer says, we're not gonna pay for it, it wasn't medically necessary. There's that internal procedure that they can appeal that goes to the insurers. But once that's exhausted, it comes to our office if they request it. And our office has 13 registered different IROs that we rotate with. And so if we're contacted by a consumer and they say, we want to appeal this, we sort of, we're the agency behind that ensures it happens. We say, okay, this is the next IRO, send them the documents, and then they'll independently look at that and make a determination. We don't do that many. We do 25, maybe 30 in a year. But the majority, 75 to 80%, are ultimately found in favor of the consumer. That's what we've seen in the last few years. So it is out there. Now, we've contacted these IROs that are registered with us. They don't have to be registered with us. That's on their own. That's on them if they want to do it. They tell us they won't comply with this one because we're such a small state. And they do so few of these here. They're not going to go to and make sure, the people that they employ, all these doctors, all of these specialists then have waved into Wyoming. They can't find that many specialists out there. And so it is a concern. And so ultimately, that puts us in a predicament. We have the issue of, I don't know if our office will find any IROs. And if we do, I'm certain they won't be licensed in Wyoming. And so they're meaningless to us. And that's potentially a consumer benefit that would go away. If I can't find that, I'm not sure what I do with that. I really don't, because there's a requirement in the statute for me to do that. But if the IROs aren't there, if they're not licensed, if they can't comply, I can't use them. And then secondly, if the insurers can't find IROs to do some of these processes, how do I hold them accountable? Because I'm really not sure. I don't know if it's in the state's best interest for me to hold an insurer, for example, and fine them or punish them when the companies aren't there. If they are there, I get it. But my understanding at this point is they're not available, and with the number of specialties, it's going to be a very, very difficult lift. So with that, I'll stand for questions.
Any questions from the committee for the department? Representative Yin.
Mr. Chairman, thank you, Commissioner Rude. In the case of the constituent that was brought, and just to generalize it, that say another person had that same case, they could have come to the insurance department to try to get that appealed? Is that correct?
Madam Chairman.
Commissioner.
Representative Yin, that was a pre-approval process, which is different than medical necessity. It's a different part of the statute. They're similar in nature. This was, it sounds to me like it was a pre-approval process. They could have appealed it, and they possibly could have appealed it a second time, but it sounded like it was an urgent matter and it wouldn't normally do that. Had the doctors just said, no, we're going to do this, it's necessary, and then the insurer refused, considered it more in line with what we see with medical necessity, and we would have been more involved with it. In this case, since it was on an emergency basis, I don't expect them to file a complaint with us, but they still could have done that after the fact, and we would have gathered the information and looked into it.
Any additional questions? Representative Clausen.
Thank you, Madam Chair. Thank you, Commissioner. I guess your testimony kind of goes along with what I was afraid of, the specialty areas and the difficulty with that. But is there any way, I think our consumers need to understand that they have some recourse through your office. And I think most people in Wyoming don't appreciate what your office can do. Can you think of some way that we could let our consumers know what their rights are and better inform them on what your office can do for them?
Commissioner.
Madam Chairman, Representative Clausen, I think it's certainly the impetus on us is to get the word out. And that's part of what we do is we try to get this information out there. It is in their policy, but as we know, as I know, I haven't read my policy that closely, and I don't expect many to others to really do that. But I will take that back to our office and we will put something out. I can put something out, into the newspapers or things like that. But we do briefings. We go to various organizations and we talk to consumers all the time, and that's something that we can touch on. And we've talked about it in the past in various venues.
Any additional questions, comments? Representative McCann.
Mainly just a comment on what you said about the doctor saying, well, we're gonna go ahead and do this. In an emergency situation, yeah, they probably will. But then you're turning, and if the insurance company denies payment to the doctor, then the docs turn around and go after the patient for the money. And that's not right either, so. Just a comment.
Madam Chair, I agree. It's complex. We still would take the complaint. We still could look at it and see if there was some avenue there for the consumer, whether it, should have been paid, and we could have done a medical necessity appeal had we gone through that route. But you are correct. It's just not as simple as we would like. But it is what we are left with. And in emergency situations, we do see that where they might come to us when something wasn't paid and thought to be medically necessary in that emergency situation. And we will get involved and look into it.
Thank you. Okay. Thank you for your testimony. We will continue to move on. Sir, did you have something? Okay, sorry about that.
That's
Go ahead.
quite all right. I'm different house here.
Okay.
Kevin
Please.
Bonnevlest, Executive Director of the State Board of Medicine, the board that licenses MDs, DOs, and PAs, and only those professions. So you know that there are a lot of medical reviews that are done by registered nurses, things like that. So what we touch is strictly MD, DO, and PA. And I thought it would be helpful to the community to go back and just take a look at the language as it exists now in the statute. And I don't have the actual bill with the line numbers on it, but in section 104A, Romanet 3, you'll see it starts off with, unless otherwise required under Wyoming law, then someone must have a license in a state, a territory, whatever. And that language was part of the compromise because many years ago, I could tell you it's at least 25 years before my time, the legislature saw fit to put in the Wyoming Medical Practice Act that the determination of medical necessity is the practice of medicine in Wyoming. So we worked with everyone who had been working on this bill with Representative Clouston and said, look, we don't want to undercut what the legislature did in the past. If you want to take that back out of the definition of practicing medicine, that's one thing. But if you want to leave that in the Medical Practice Act, can we have this carve out? And this was the result of very good drafting by the general counsel of the largest health insurer in the state. And I thought it was a very elegant solution to say, if there's something in Wyoming law elsewhere that says you have to have a license, then you have to have a license in Wyoming. Otherwise, like for instance, a nurse, I don't think the Nurse Practice Act requires it. So that's why this language came in, was to accommodate those spots like in the Medical Practice Act. And just to help a little bit, if I can address, for instance, Representative Ottman's question regarding telehealth, I believe every state in the country, every territory feels that the practice of medicine occurs at the location of the patient, the physical location, for exactly the reason that the sponsor of the bill brought forward. If, say, a doctor in Connecticut does something inappropriate, whether it's injures a patient or fails to follow proper procedures or whatever, that patient really shouldn't have to go to Hartford, Connecticut and find the medical board there and say, hey, this guy fouled up. Because think about how far away that is, both physically and just practically. And similarly, if a physician from Wyoming did something to someone in Connecticut that they didn't have a license in Connecticut, the Connecticut board would have almost no ability to investigate in Wyoming. So that's where, at least in the practice of medicine, we said practice occurs where the patient's located, because if you don't have a patient, you're not practicing medicine, with few exceptions, or you have some sort of human situation in the case of a prior authorization. At this point, I will contact the sponsor of the bill, because it sounds like we should have a conversation about the case that he brought up and the physician who was in Connecticut allegedly doing prior authorization for a patient in Wyoming. Because under the Medical Practice Act, they should be licensed in Wyoming regardless of what this law says as it reads right now, just because that's what the legislature put in place decades ago. And so we do want to follow up on that. But the better way to do it, of course, is to say be licensed in Wyoming, because then that way it's a very clear, we can reach out and touch you because you're taking care of Wyoming patients who are in Wyoming. So that would just be my sort of recommendation to you all, is to make sure that we are able to continue to do that. And we will follow up once I get the information from the bill sponsor on just exactly what, we may have misspoken in our office. I don't know. We'll clear that up and find out what we can. And then all that said, from the Board of Medicine perspective, it is what we need as a tool to be able to investigate cases like this as it exists, provided they follow our law, which is they're supposed to be licensed as a physician or PA in the state. If I will just offer this sort of outside of my wheelhouse, outside of my playground, but to the extent that I can help with drafting something that might address these concerns without going to full-blown licensure, I'd be happy to work with anybody on that. Because we found during the public health emergency for COVID, we wanted to bring in physicians and PAs to work in Wyoming, and we didn't want to put them through the full licensure process, what we hoped would be a short period of time. So we've developed ways where we can have somebody come in, we know they're working in Wyoming, we have a way to reach out and touch them if we have to, but they've not gone through the full licensing process. I think we could take a process like that and adapt it here if it's the consensus of the committee that you want to move something forward, but this isn't quite it. But all that said, again, from my board's perspective, the law as it exists allows us to investigate cases such as the one the sponsor brought up, and we will certainly do that. So with all of that cloud there and all that, I hope I haven't made things too murky, but if I can answer questions, I'd be happy to.
Any questions from the committee? Representative Clouston.
Thank you, Madam Chair. Thank you for the testimony. So just to make sure the murkiness is gone, it's your suggestion that we leave the language as is and not enact what this current bill is saying to change?
Madam Chairman, Representative Clouston, I'm not saying what you should or shouldn't do. That's your decision. I think if you really wanted to get at this a little bit more and get more reach to, say, the registered nurses who are doing determinations, or the dentists, or the chiropractors, or whatever else, because I don't know who all the insurance companies and IROs hire, then I think we can do that, modifying the language that's here. The language that's here is so broad that there's no way to kind of distill it down. But if you want to wordsmith it, well, I'll be happy to work with you, and also I can get my peers from the other licensing boards that might be involved, and we can help work on this. But so at this point, I'm not going to say that it should stay this way, but the Board of Medicine is satisfied with the way the law exists right now.
Thank you. Vice Chair Ottman, if you still have your question.
Thank you, Madam Chair. Part of my question was answered. Could you please tell me your last name again and the board that I can't quite read it.
No, that's quite, yeah. Anyway, now Kevin Bonenblust, BOHNENBLUST. And obviously you're new to the committee because you haven't had to listen to me before. And I'm with the Board of Medicine, MDs, DOs, and PAs.
Thank you. Go ahead.
Thank you, Madam Chair. Secondly, how are traveling nurses and things like that handled currently?
Madam Chairman, Representative Ottman, again, I tread lightly because that's not where I work. I don't work in the board of, with the Nursing Practice Act, but they've got different provisions. Traveling nurses used to be, they would be licensed in the state. They've got a very robust interstate licensing compact. We have a very robust one for physicians. We've actually grown now bigger than the nurse compact in terms of state participation. We've put a lot of tools in place. I believe they've got ways to do it. I am very careful, though. I won't try to opine on what their process is.
Madam Chair, okay, so then to follow up, is this doctor from Connecticut then through a compact or something? Is that the reason why he may have been, or she may have been approached about this diagnosis?
Madam Chairman, Representative Ottman, I'm a little hesitant to speculate, but I would say that if the physician was licensed in Wyoming through the compact, there would have been no question. We would have investigated because they held a Wyoming license. If for whatever reason we said we can't, it may well be that they don't hold a Wyoming license. And there's a lot of opinions out there in the ether about whether or not you're practicing medicine by doing a pre-authorization, whether you're practicing medicine reading a film for an x-ray or whatever else. But the bottom line is that we always say if you're affecting a patient in Wyoming, a specific patient, and it takes an MD or a DOPA behind your name, then you are practicing. So my guess is this physician is not licensed in Wyoming, but according to the Wyoming Medical Practice Act, probably should be.
Thank you. Representative Yin.
Mr. Chair, Madam Chairman, sorry, and Mr. Bonenbless. You talked about being able to work with the sponsor about wordsmithing the bill, but the bill title is pretty tight to the actual wording that's in the bill. I'm not sure how much wordsmithing that we can do within the bill. And frankly, I mean, it sounds like the intent of the bill is based on a miscommunication maybe with the Board of Medicine and that constituent. So if you have language that you can think of that would fit within the title, happy to hear it, but I don't think the bill as is quite workable if we're asking for changes here.
I'm sorry, I was just rereading the bill, Madam Chairman. Representative Yin, I of course defer to you all and how legislation works in terms of does the title pick it up? But on the other hand, I think there could be a way, and I'd certainly be happy to explore that. Wordsmithing is kind of a fun thing. And so we can give it a shot if you'd like us to. And if not, well, then we'll let you decide what else you want to do.
Okay. Any other questions? Seeing none, thank you all for your testimony.
Thank you.
We will move on to, is there any other government agencies? No. Okay, we'll move on to public comment. Anybody from the public in the audience that would like to come up? We have one on Zoom. Thank you, Mr. Caldwell. If you can bring them in. Right. Okay, bring Mr. Spencer in. Okay. Welcome, Mr. Spencer, to Labor and Health. Please state your name and your group, or whether or not you're testifying as an individual, and we'll hear your testimony. Gotta unmute. We're unable to hear you, Mr. Spencer. You've tried to unmute yourself there? Okay, you'll need to turn your mic on, it sounds like. You are unmuted, but maybe there's a feature on your computer there. Okay, we can't hear you. We're gonna go ahead and move on, Mr. Spencer. I apologize. I would invite you to perhaps email or call our committee members to address your concerns regarding the bill, whether or not you're in support or against the bill. So sorry this didn't work out. Mr. Caldwell, are there additional?
There's one more, Madam. Ralph Hayes.
Okay, bring in Mr. Hayes. In committee, it looks like we are winding down here before the body convenes. Welcome, Mr. Hayes, to Labor and Health. If you can just tell us who you are and what organization you're with, or if you're an private individual, we'll hear your testimony.
Madam Chairman, members of the committee, my name is Ralph Hayes. I'm basically a retiree from the state, formerly with Employees Officials Group Insurance Program, and wanted to speak upon this particular piece of legislation. Can you hear me?
Yes,
I
we
guess-
can hear you just fine. Please proceed.
Okay. You know, one of the things I'm found with this particular piece of legislation, there was definitely a situation which Commissioner Rude put into place with the internal review organizations, and the fact that that's available to every individual who has a adverse determination through a medical necessity. So in this particular case that was mentioned out here, most likely the hysterectomy wasn't approved as not being medically necessary, but the other procedure was approved. Now, anybody, and it's in everybody's booklet, and that's required by state law, they can move forward with the individual review organization through the Wyoming Insurance Department as far as the end part of their appeals process, which and the findings are final based both the insurance company and the member at that point in time. So there is an appeals process available which utilizes it. And again, when you're looking at Wyoming is 1.7% of the USA population. Getting insurers, your independent review organizations to bother to go through a Wyoming licensing process for such a small portion of their volume becomes problematic. And it's going to have some unintended consequences, I believe, as far as services to our members. And it's also going to be expensive because there is a cost of implementation anytime you're dealing with this, as was mentioned earlier in the previous bill. Trying to get specialists, especially, and that's the primary focus here, licensed in the state to be able to do these determinations is problematic, if it's possible. So I think what we're doing is we're actually encouraging insurers not to do business in the state of Wyoming. We have few enough out there already. When we were going through RFP processes, asking for third-party administrations or independent review organizations or whatever, the group of individuals and companies are getting smaller and smaller as far as willing to do business in the state of Wyoming. And we're putting one more barrier in front of them, which is going to make doing business in the state of Wyoming for 1.7% of the population, it just becomes more problematic. So from my perspective, because there is a complaint process out there through the insurance department, that's the appropriate venue to move through this. If somebody is upset with a physician who did an independent review, that state, you can go through their process, but we just don't have enough providers in the state to do the reviews and the volume of reviews in this state. And I just believe that removing this existing language is the wrong direction. And I stand for any questions by the committee.
Thank you, Mr. Hayes. Any questions of Mr. Hayes from the committee? Vice Chair Ottman.
Thank you, Madam Chairman. Mr. Hayes, you said the volume of complaints. So am I thinking that there is definitely a problem that needs to be addressed, but because of the low population here, we don't get all the attention that we may get. The other thing, and if you could address this, would be how, what, who is addressed if there's thoughts of malpractice. I mean, do you have to go through the procedure and then go through payments and insurance and all of those things to look to say, well, there was some malpractice going on? I mean, and not to get into a long haul, but just as a consumer, I would not know that I should contact the Board of Medicine, that I should contact the Board of Insurance, that I should contact all of these places. So what is a more usable action by the consumers, if there is one?
Well, first of all, this goes down to the appeals process. When an adverse determination happens within an insurance companies, they receive written notifications, which talks about that the adverse determination was made and that there's appeals processes available. So there's the internal review processes available through the insurance company, and that's the first step. But also right within that notification is the notification that the state process through the Wyoming Insurance Department is available also for adverse determinations for medical necessity. So they're already receiving information through an adverse determination on how to appeal the determination. Now, in the particular circumstances, and it's been mentioned before, medicine is more of an art form than a science. We go through an appropriate procedure. Something happens during that procedure because of a unique biology of an individual or circumstances, or they find something that they weren't aware of. So if something else has to be done, insurance companies do take that into effect when they do their payments. That's part of the appeals process. So yes, I can understand somebody who says, well, I thought I was only going to be out for a certain amount of time, but because something additional happened, they were out farther. Is that really the physician's fault who did the adverse determination? It's just one of those things that does pop up. And I understand them being upset with that. I would be too. But that's not necessarily because a bad determination was made. There was some underlying condition there that nobody was aware of that made the procedure done not handle the situation. I hope that helps.
Thank you. Okay, thank you for your testimony. Thanks for joining us today. Is that the last one on Zoom? Okay, thank you. All right, any registered lobbyists that like to come up? Welcome. If you'd each please state your name and who you're with, and we'll get started.
Good morning, Madam Chairman, members of the committee. Kelsey Prestisator with Blue Cross Blue Shield, Wyoming.
Madam Chairman, Raymond Red, Blue Cross Blue Shield of Wyoming.
Madam Chairman, members of the committee, Mike Mosier, Cigna.
Welcome. Go ahead.
Thank you, Madam Chairman. So we'll keep this very brief. I think there's been a lot of good information that's been shared with the committee already this morning, but we just want to express the real impact that this bill would have on our members as an insurer here in Wyoming. Our medical directors are licensed in the state of Wyoming, but as you've heard this morning, the real issue that we're going to run into here is with the independent review organizations not having adequate providers to conduct appeals, a review of appeals within the state of Wyoming. And that's a real problem because we want to make sure that the people that we are insuring have their full due process rights in the appeal process. That's very important to protect. And if there's not adequate providers in certain specialties who are able to conduct these reviews and who have the adequate experience and expertise in the specific practice area to conduct these appeals, then there's really no option for individuals who are in need of medical care, who are going through this appeals process, to have a fair shake at getting a decision that is going to be right for them. And I just want to touch on a little bit the main purpose of this bill, which is to provide recourse to individuals who may feel that their provider has acted inappropriately. And I just really want to point out that as the Department of Insurance has noted, as well as others, the Department of Insurance does have an option for individuals to reach out if they have a complaint. And likewise, complaints with the boards of medicine in every state are oftentimes filed online through a written process. And so there's really no additional barrier to people that are seeking redress against providers. So that's a process that's available to them as well. And then I will just also note that providers through the IROs are required to adhere to various federal accreditation standards and requirements that really provide stringent standards for their experience. A lot of these providers are members of research institutions, and so their experience is really above and beyond what you might even get with some in-state providers that would be reviewing claims. And so, like I said, there's been a lot of other information that's already come out this morning, so I won't belabor the other points, but I just wanted to point some of those items out and why it's important to protect the integrity of the review process that already exists and has been put in place in the state, and why it's important to protect our members as insurers and make sure that their rights are maintained. Thank you.
Thank you. Go ahead.
Madam Chairman, once again, Mike Mosier, Cigna. I'll be brief. Our major concern, we have major concerns with this bill. I think prior authorization, I've been in more task forces and coalitions than I could ever care to count. We put in hundreds of hours individually on the prior not collectively, individually on the prior authorization legislation, which is still going through rules right now. And my concern is this bill's unintended consequences. I realize and I salute the good bill sponsor's intent, but we've heard tonight, or today, this morning, feels like tonight, that there's a lot of other things that could have been done. Now, I realize there's discussion about fixing this, but my experience, for what it's worth, is it's a lot easier to write a good bill than to fix a flawed bill. And as we move into the interim, we can certainly be involved in discussions with the good bill sponsor and others. I think the awareness of the process through the Department of Insurance and Board of Medicine is vital because those already exist. So we'd ask that you would oppose this bill. There's certainly time down the road to do anything statutorily. But like I said, right now, the current prior authorization legislation is still in the rules process. And so my concern is this is too early, too fast, and too quick. Thank you.
Thank you. Any questions for Blue Cross Blue Shield or Cigna? Representative Clauston.
Thank you, Madam Chair. I guess, and to all three of you, would you be willing to put out in your newsletter, just kind of informing your clients, right? What some of their recourses can be when they're not satisfied with what, you know, their first process. Let them know what their appeals process looks like.
Go ahead, any of you?
Madam Chairman, Representative Clouston, we will absolutely talk with our provider relations folks about that and your request. And we do put out a newsletter, and they actually look for a lot of feedback and would like more topics and opportunities. We talk about that internally. How can we help our members? How can we provide more information on your good recommendation? I'm sure they will be happy to put that in there. Thank you.
Madam Chairman, Representative Clouston, yes, since we have the EGI as well, we can certainly raise awareness of that process.
Thank you. Any other questions from the committee? Representative McCann.
Thank you, Madam Chair. As a provider, I think part of it is not all insurance companies are created the same. I mean, there's some people that I do a lot more peer-to-peers with than others. And that's can be aggravating for sure. Now I'm an orthopedic PA, so there's not too many emergencies that we have to do. But I fully understand, you know, the intent of the bill. And I think it's a good idea, but at the same time, I do agree with you, sir, that it might be a little bit too much too early. Thank you.
Thank you, Representative McCann. Okay, thank you for your testimony, all of you. Thanks for joining us today. Any additional registered lobbyists out there that would like to come up? No? Okay, with that, we will close public comment. Committee, what is your pleasure? Okay, it appears that the bill has not been moved. We had one other bill that was on our agenda. That was House Bill 96, prohibiting mask, vaccine, and testing discrimination, sponsored by Representative McCann, that we did not get to. We will move that bill to our next meeting, which would be Monday at 8 a.m. So please join us if you were here or interested in testifying on that bill. Seeing no further business, our meeting is adjourned. Thank you, Mr. Caldwell, for all of your help.